Okay, second lecture of chemotherapy, and again, this one's not testable. I want to stress that. I'm going to go through this pretty quickly. You can review this on your own too, probably by just looking at the slides, but I figured I'd just go through it to make sure I covered it for completeness sake. So we'll start with leukemias. Childhood leukemias are usually relatively decent prognosis, fortunately. Acute lymphoblastic leukemia is the most common childhood cancer. Our therapies are usually vincristine, prednisone are the core two, plus you're adding some sort of alkylating agent, usually like cyclophosphamide. And then most patients will get into remission with minimal toxicity. So it's short course, relatively low toxicity as far as our regimen goes, good prognosis. You can also inject methotrexate intrathecally. This can be used as a prophylaxis in case the cancer cells migrate to the brain. It is a standard component for induction therapy before chemotherapy to make sure that nothing's metastasized into the brain. Adult leukemia, the most common one is acute myelogenous leukemia, or AML, and therapy is cytarabine plus one of the anthracyclines. Idarubicin is preferred, but there's some other ones that could be used, and it induces about 70% remission. Supportive care during induction therapy is pretty intense. Usually it requires a lot of platelet transfusions. Patients tend to get really low platelet counts. Colony stimulating factors are used aggressively. Patients are usually on a substantial amount of antibiotics because their immune system is getting destroyed because of this therapy. Patients in less than 55, if they have undergone remission, could be candidates for bone marrow transplant. And 55 is probably not an absolute cutoff, but that's generally the rule of thumb, I think. And consolidation of chemotherapy, post-remission, high-dose cytarabine monthly for 3 to 4 months may be indicated for certain patients once they've gone through and gotten into remission, just to ensure you're killing any possible residual cancer. CML is chronic myelogenous leukemia. It's treated once white blood cell counts are greater than 50,000. So white blood cell counts will go up, and then all of a sudden they're high, and we need to treat them. And this is where our drug Gleevec comes into play. It's a very popular choice here. It's our tyrosine kinase inhibitor, and again, we talked about this a little bit already. Some other options you can consider are other tyrosine kinase inhibitors. Basically, once Gleevec got popular and on the market, some other drug companies made their own versions. There's some oral alkylating agents out there. So while a drug like cyclophosphamide is primarily used intravenously, it also does come as an oral option too, so that could be given. There are a couple other ones that are similar. And hydroxyurea is a drug that prevents ribonucleotide conversion, and what that does is it halts cycle G1S phase. CLL is chronic lymphocytic leukemia. The early disease shows relatively good prognosis. Cyclophosphamide, chlorambucil is an older alkylating agent not used very often. Cyclophosphamide would probably be your drug of choice here. We're going to add on to that our CHOP regimen, so usually vincristine plus or minus doxorubicin. Other options, bendamustine is a newer alkylating agent. Fludarabine is a newer antimetabolite. Rituximab, which is our CD20 antibody that can work against the body's natural defenses, also works with this to enhance the cytotoxic. So it's usually given in addition to our CHOP regimen or another regimen. There's another drug called alemtuzumab, which is Campath, and we'll talk about that again a little more during transplant, which really does wipe out a lot of the body's immune system. So it's kind of a last-ditch effort for people who have tried a lot of other therapies here. Hodgkin's lymphoma is a B-cell neoplasm. Epstein-Barr virus is associated with up to 80% of the cases, interestingly, or which also known as mono. Stage 1 and 2, brief chemotherapy and radiation is usually effective. Stage 3 and 4, there's a regimen called ABVD. Apparently they couldn't think of a fancy name like CHOP for this one. But doxorubicin, bleomycin, vincristine, and dacarbazine are all used for these. And it's one of the newer regimens. There's also the Stanford 5, which is listed down there too, which has a lot more stuff to it. These regimens are both fortunately fairly effective even for late stage, and most people can go into remission with one of these regimens. Non-Hodgkin's lymphoma, there's nodular versus diffuse. Treating diffuse patients, you have high intensity chemo. CHOP plus rituximab does work for non-Hodgkin's lymphoma. and nodular or follicular, you're looking at a different type of chemo approach usually, because the low grade growth factor, slow growing tumor. Chemotherapy is not as responsive. Survival is better long term than diffuse because it's not quite as prevalent in the body, but it is slow growing, so it's difficult to treat it as well. If it's in an advanced stage, it's so hard to treat with drugs that you usually can't do much about it. Some other cancers, multiple myeloma is a cancer that involves bone marrow and bone pain, lesions, fractures, and anemia. There's a treatment called with an alkylating agent called melphalan. There's some newer therapies too. Lenalidomide is an immune modulator. You can add on dexamethasone, which is corticosteroid, to that. And then there's a newer drug, bortezomib, which inhibits protein homeostasis and causes apoptosis. This drug is kind of interesting because it's a proteasome inhibitor. So it's a drug that blocks the action of a proteasome, which is a complex that breaks down different types of proteins. So you end up with a drug that it's kind of a newer drug that hasn't really been used a lot in other areas. The concept of using it is you're causing a pretty massive change in intracellular peptides, which is going to promote cellular apoptosis eventually. Refractory treatment of multiple myeloma, thalidomide is a drug similar to dexamethasone, and then maybe a more traditional regimen like vincristine, doxorubicin, maybe more broad spectrum, heavy-duty chemotherapy regimen. Breast cancer, stage 1 and 2, small tumors with no lymph involvement. Surgery alone is usually fairly effective for this. If the lymphatic nodes are involved, you're going to look at cycles of chemotherapy. So there's CMF or FAC, which are listed there. There's some alternate regimens too, different cycles of chemotherapy or options. Again, we're going to talk about this a little bit more with breast cancer, but there is a specific drug called trastuzumab or Herceptin. HER2 is a specific subset of receptors that's found, and you can do a specific test to see if the cancer is HER2 positive. It is HER2 positive. Tumors are HER2 positive. This is a biologic drug that works quite well for that specific subset. However, this doesn't apply to every patient. And you're looking at about 5 years of hormone manipulation following any of these regimens. Stage 3 and 4 breast cancer is difficult. It's often a palliative effort, meaning we're usually looking at supportive efforts to make sure the patient's comfortable. Not necessarily like hospice care, but we want to make sure that patients living their life to the fullest and being able to do that at the same time approaching any possible treatment option with fully vetting it if it's a potential for a cure. Therapies for stage 1 and 2 can be used as well. The response rate goes down quite a bit. Metastatic cancer is not very beneficial from hormone therapy, so at that point you're looking at pretty broad spectrum chemotherapy, and out of these, even if they respond, only about 10 to 20% will get complete remission. Prostate cancer treatment is usually chemical or surgical castration to decrease the amount of hormones being in the body, and we can also give anti-androgen or estrogen to also prevent. The reason behind prostate cancer, again, we'll talk about this more during Men's Health, is you get a testosterone derivative called DHT, which is much more potent, which is generally the cause of prostate cancer. So we want to work against that if we can. Refractory treatment involves docetaxel, prednisone, and then you have a couple other drugs too. There's about 40 to 50% response for refractory prostate treatment. I should say also, I didn't mention on this slide, but you also have varying degrees of prostate, of course, just like you would with anything else. So surgical resection may be quite easy and an easy cure for prostate. Otherwise, if it's metastasized or gone into lymphatic tissue, you're looking at a more challenging treatment, just like with breast cancer. GI cancer, colorectal is the most common one. It's about 40 to 50% curable with surgery alone. People with high risk for high-risk surgery or involvement that surgery doesn't think they can adequately resect, you're looking at a variety of regimens listed there. Metastatic is, again, going to add on to these regimens. There are some biologic agents that have been shown to be effective for the colorectal tumors. So bevacizumab or Avastin, our VEGF inhibitor, works for this. There's a couple other ones as well too. Survival is quite low even with the drugs we have when it comes to metastatic cancer of any kind, really, in colorectal is not an anomaly there. Other GI cancer, stomach, esophageal, it's quite rare, but it's very aggressive. Most cases, you can't really resect it surgically. You use some alkylating agents plus some other drugs too to try and mix them together. Clinical response is about half and half. Herceptin, positive breast cancer agent, trastuzumab, actually has been shown to maybe work in this area, believe it or not. We don't really know why. Combination chemo plus radiation prior to surgery is usually indicated. So we'll try and beat down the tumor with chemo, radiation, and then approach surgery if possible. Pancreatic, if you remember from that first couple slides in the last lecture, high death rate, high mortality rate. Chemotherapy does not provide a lot of benefits, maybe some modest mortality benefits. You might get some quality of life improvements for a little bit of time. Really don't have much that works. There is a tyrosine kinase inhibitor on the market called erlotinib, which could be a promising therapy, maybe combination with a platinum agent potentially too. But the pancreatic cancers are very difficult to treat. There's not a lot you can do. Lung cancer, non-small cell, is the more common one. The prognosis is pretty poor if you find it in an advanced stage, just like with any cancer, and the survival is probably only about 8 months. Smoking is obviously heavily linked to lung cancer, and you can prevent that by smoking cessation. However, you can get lung cancer even if you aren't a smoker too, and those patients may not necessarily be aware of their risks per se. I know radon exposure is heavily associated with lung cancer, and it's something that most people may or may not even know that they are exposed to on a regular basis if they do have high levels of radon in their home. Some advanced cases, you can use a mix and match of a variety of chemotherapies, including some biologic agents like bevacizumab, and tyrosine kinase inhibitor erlotinib is also approved for some different types of lung cancer. Small cell is a more aggressive form. It's the less common one. The basic disease is, fortunately, pretty highly sensitive to platinum-based regimens. Because it's aggressive and fast-growing, again, we can treat it a little bit better because our drugs are going to work more on those fast-growing, high-growth factor tumors. Cisplatin plus or minus etoposide or irinotecan are regimens that work. Sometimes extensive disease will develop resistance to our platinum-based regimen, so you usually have to look at switching to a topoisomerase inhibitor like etoposide or topotecan. Ovarian cancer is difficult because it's usually pretty undetected in most people until it metastasizes into the peritoneal cavity. Once it does that, you're probably looking at advanced stage ovarian cancer, and then that's why ovarian cancer mortality is so high, because most people don't realize they have it until it's too late. It's kind of similar actually to pancreatic cancer. You have stage 1 and 2 whole abdomen radiation plus chemotherapy. Stage 3 and 4 looks at chemotherapy options, mostly as a salvage treatment. It's very difficult to treat. Testicular cancer, about 90% of patients will respond to chemotherapy, and 70 to 80 will go into complete remission. Treatment, you have about 3 cycles of a regimen called PEB, which is cisplatin, etoposide, and bleomycin. You have 4 cycles of cisplatin and etoposide alone. The results are pretty similar. The high-risk disease might use a more broad-spectrum approach, and also look at increasing the doses of the drugs we used above. Malignant melanoma is pretty, we're looking at skin cancer treatment. So you can resect tumors locally. If they've metastasized, it's very difficult to treat it. So when we're talking about, I mentioned that immunotherapy that's useful for injecting into skin lesions. That'll work locally on the skin lesion, but the question is, how do you treat the metastatic component of it? And that's where cancer treatment is very challenging. There's a couple agents here, and there's some biologic response agents too. Response is generally low, even with the with the skin lesions, not to mention the metastases. So that's why this new drug that's an immunotherapy is seen as kind of maybe a little bit of a breakthrough. The mortality benefits, fortunately, aren't all that great with it, but it does show some promise for future developments, hopefully. Chemotherapy has a pretty limited role for brain cancer. A lot of drugs don't cross the blood-brain barrier. There's a couple that do. The nitrosoureas, or the ones that end in mustine, have pretty good blood-brain barrier penetration. And then we have our drug bevacizumab or Avastin, which can work to decrease blood supply to our brain tumors. There are some tyrosine kinase inhibitors under study for brain cancer, but there's none that are approved yet. All right, so that was basically a brief review of systems and some common cancers that affect the body and where we're looking. And again, I'm not going to test you on any of this, so it's purely for information if you want to put some context to the lecture we just talked about. But until then, I'll see you on Monday. Thank you guys for listening.